Molina, who's an endocrinologist at IU and a diabetes researcher, and she's going to give us her presentation in about 30 minutes.
30 minutes, I can do it.
30,
and
35?
I have a lot of slides, but they're just a place to start. So if you prefer to stop and ask questions, we can certainly do that. I've prepared some information, but I don't have to get through any of it. So if you'd like to stop and ask me questions, whether it be about your wife, your mother, yourself, feel free. I'm yours for the next 30 minutes. So I am in a larger group, the Herman B. Wells Center Program in Diabetes Research. This is just our entire group. There are 4 principal investigators, we call it, or 4 leaders of these smaller groups in this center, where you can see a little bit of the Choluli statue. I don't know if you guys have been on the campus at IU, but the same sculptor who has a lot of things at the Children's Museum has a DNA double helix in our office building, which is really nice to look at. So this is my group. It's small now because I'm just a couple years out of my training. So I've been at IU for about 2 years. So we're growing, and I think we're doing some exciting things. And I'll have an opportunity at the end, if we make it there, to share some of our projects with you. But I have a really very energetic, very nice group of people that I work with. So I'm going to talk about diabetes. That's the disease that I think about every day for many hours a day. Either I'm taking care of patients in the clinic, so I take care of patients in the IU hospital, the Wishart Hospital, when they're admitted. And they may have either a reason that they're admitted is for diabetes, or they have diabetes which is complicating their stay. And I also take care of patients at the Veterans Hospital, where I see patients every week when they come to our clinics. So what is diabetes? It's a lot of people say it's not even a disease per se, it's really a syndrome. That means it's a lot of different things all wrapped up into one definition. But it's when the body doesn't properly control the amount of glucose in the blood. So basically what you see, and if you know anybody or have diabetes yourself, you know that you get hyperglycemic or you have a high blood glucose. Now when we treat you and give you all of our medicines, we can also make you have low blood sugars, which is an important part of the disease as well. And so really it occurs when either you don't make enough insulin or you don't respond to the insulin that you have appropriately. And I'll tell you a little bit about how that kind of plays into what diabetes is. And basically the reason that we care about this is it's a really big problem in our society. It's a major cause of a lot of complications. And Pam has alluded to some of those, but it can really affect a lot of organs in the body: the eyes, the kidneys, the nerves, the heart. So unfortunately, it's becoming more and more of a problem in our world, and we've exported this problem to a lot of other countries. So 24 million people in the US have diabetes. About 57 million more are considered to be pre-diabetic. And this one scares me because I have 2 young daughters. So for children born after the year 2000, their estimated lifetime risk of developing diabetes is about 1 in 3 if they're male, 2 in 5 if they're female. So that's a third, up to a third of our population having diabetes. And unfortunately, we're getting it younger as well. So that means many more years of having these complications. 246 million people worldwide. So what does it do? It is a leading cause of death due to heart disease, stroke as well. It's the leading cause of kidney disease in our country, the leading reason that people go on dialysis. It's the leading cause of blindness in adults, and the most frequent reason that people have amputations because of the peripheral vascular disease. I think you guys are very aware of Dr. Murphy's research. Now, diabetes, we think of it as a contemporary problem, but really it's been around forever. I just want to share just a few highlights of the history. It's really kind of a very interesting story. So if you go back to 1552 BC, you can find mentions of it in a lot of ancient documents. And mostly they talk about it in the terms of somebody who has a lot of urination. So they're going to the bathroom to urinate a lot. And it wasn't until it was kind of named around 164 AD. And it was given the term diabetes, which means siphon, or people are urinating, going to the bathroom a lot because their blood sugar is high. And then, I don't know about you guys, I've had a lot of bad jobs in my life, but never one as bad as this. So they gave it the name mellitus, that is Latin for sweet or honey, because there were people who would taste the urine and it tasted sweet because there was a lot of glucose in it. So physicians back in the day used to have to taste the urine to determine what their patient has. And then in the late 1800s, Langerhans described these two systems of cell in the pancreas that I'll kind of tell you about. And those are some of the sort of early pioneers in this disease. In 1919, this gentleman talked about and put forth these papers about the total dietary regulation in the treatment of diabetes. And basically his cure was to starve people. And he found that that helped their blood glucose. And then really and if you think about this, it's not that long ago, 1921, there was a revolution. I mean, things changed dramatically. Banting and Best, who are Canadian researchers, discovered insulin. And they were able to synthesize it in their labs. And the first patient, James Haven, was treated in 1922. So that's not that long ago, really, that we discovered insulin and were able to treat patients with it. So, and then this is just an illustration of a patient with type 1 diabetes before treatment. You can see how emaciated she is and thin, and then after treatment with insulin. So you guys may have seen these slides before. And it's a set of slides that the CDC puts on their website looking at the incidence of diabetes from 1994 to 2008. And it's a series of slides, so I'm going to let you watch it, but I want to orient you to what you should be looking at. So basically, what you should have your eyes look at are the dark colors, so the reds and the oranges coming on. And so the red is a greater than 9% incidence. And so Indiana is about a 9% incident rate. And then the darker colors mean more and more people getting diabetes. So let's just take a look at the maps of the U.S. We'll talk about that. So so you see the darker colors coming on. Most things happen in the south, so it starts in the south, but then look how it kind of spreads throughout the country. So you see the red colors. Yeah, so there we are in 2008. So if you look at this, here I've got maps of the U.S. looking at the trends of obesity or being overweight. And then also, those are the top maps. And then you can see the darker colors mean more obese. And then you can see the incidence maps of diabetes. So they parallel. So a lot of the reason that we're seeing more and more diabetes is that we're putting on weight as a country. We're eating more. We're eating larger portions. And that's leading to an upswing in this rate of type 2 diabetes. Now, if you look very carefully at the incidence of type 1 diabetes, and I'll tell you a little bit about the differences between those, that's increasing in incidence too, unfortunately. And that's less well understood. There's probably some environmental factors. But just a little vocabulary, the cell that I study is, or group of cells rather, are the pancreatic islets. So that's where the insulin is produced. And type 1 and type 2, you have problems with the islets. And these are small little islands or masses of cells in the pancreas. And there's about 5 million islets per pancreas. And unfortunately, for most of us, what we're born with, to some degree, is about what we get. There is some plasticity in the tissue that I'll show you, but it's a very small group of cells, and we have to protect them. And unfortunately, some of the things that we do are damaging to the islet. So within the islet, there are a number of hormone-producing cells, and the one that makes insulin is the beta cell. So these are little pictures of islets in the pancreas. The pancreas also makes digestive hormones, so you can see they're kind of transported in these ducts here. This is an islet that's stained for insulin. So insulin is a predominant hormone made by the islet. When the beta cell doesn't work, we have to give insulin exogenously. So unfortunately, that can mean a lot of injections for patients who don't make a lot of their own insulin. So we talked about this, the hallmark of diabetes, high blood glucose. And basically, so what is insulin? Well, it's a hormone that's secreted, and it really has effects on a lot of organs in the tissue, in the body, and nearly every tissue. 3 main targets are the liver, the fat tissue, and skeletal muscle. And basically, it helps you store nutrients. So what insulin does is it helps the muscle, the liver, and the fat tissue take up glucose. So the glucose that we eat, insulin acts on these tissues to make the glucose be taken up into the cells where it can be used for energy. So we diagnose it when someone has an elevated blood sugar And most of the times we try to get a fasting blood glucose. We may do an oral glucose tolerance test where we give them a glucose challenge, measure their blood glucose afterwards, or we can do a test called a hemoglobin A1C. Signs and symptoms that is often more practical for you to think about. So people going to the bathroom to urinate a lot, they're drinking a lot, and they're eating a lot. Those are the three sort of classic Ps, the three Ps of diabetes. Not feeling well, losing weight because you can't store that energy. Blurry vision, it affects how the lenses in our eyes see. So when your blood glucose is high, the lens in your eyes swell, and you don't focus as well. And then frequent infections, because we know the high glucose can suppress our immune function. There are a number of different types of diabetes, the most common type 1 diabetes and type 2 diabetes. Women are at risk to develop gestational diabetes because that's a state where the placenta produces a lot of hormones that don't make our insulin work so well. And then prediabetes is a real problem in our country as well. And then sometimes we can get other diseases which cause us to get diabetes. So again, beta cells are kind of the focus of my research. Sometimes you can get some new beta cells to form. Sometimes your beta cells will replicate. That's not as common, and it's hard to capture those sorts of things. If you have type 1 diabetes, your immune system recognizes your beta cell as foreign and destroys it. And then in type 2 diabetes, when you throw in all the bad stuff that happens with that type 2 diabetes, you have high blood glucose, your lipid levels are high, those can actually be toxic to the beta cell. And I'll sort of talk about these things in a second. So type 1 diabetes, this is a busy slide, just the main point, autoimmune. So your body recognizes your beta cell as foreign and destroys it. And again, there's probably a genetic susceptibility to that. There may also be environmental factors, so people may get a virus, and that can set up an immune response where the body can produce these destructive T and B cells, which will destroy the beta cells. And this is a picture of the islet. These small dark cells are not normally supposed to be there, and those are just immune cells infiltrating in. This is a special animal model that we have. It's called the NOD mouse. It develops spontaneously type 1 diabetes, and so it's very helpful for us in the lab to look at different factors to see if we're affecting type 1 diabetes. And you can just see the immune cells infiltrating in here. And we used to think that once you got type 1 diabetes and your immune system destroyed all your beta cells, then you didn't have any more. But actually, some very interesting data from a person in California. He had some pathology specimens from patients who'd had long-standing type 1 diabetes for over 23 years, 30 years. He was actually able to find beta cells in those specimens. So what that tells us is there is some replication. The beta cells do have a capacity to grow back, but unfortunately you continue to have the autoimmune destruction. But if you could find how to balance that, if you could affect the autoimmunity, you could make them replicate more, then you could potentially have a cure for type 1 diabetes. Now, type 2 diabetes is it's a different sort of circumstances. There is a genetic component, so we know that certain ethnic groups are at high risk. But we also know that being overweight, having a lifestyle where you're not active, it can lead to type 2 diabetes as well.